Welcome to our latest episode of Wellbeing Wednesdays, the National Council's virtual series on healthcare. Join us as Dr. George Koob, Director of the National Institute on Alcohol Abuse and Alcoholism, and Chuck Ngolia, President and CEO of the National Council for Mental Wellbeing, discuss the current state of alcohol use disorder nationwide, how COVID-19 is contributing to the unprecedented surge, the impact alcohol use disorder is having on community health, strategies and solutions for addressing alcohol use disorder in America. To start things off, here is National Council for Mental Wellbeing President and CEO, Chuck Ngolia.
Thank you for joining this 8th episode of Wellbeing Wednesday. It's September, which means it's Recovery Month, our opportunity to acknowledge that people can and do change, that people can recover from substance use disorders and lead complete and full lives, that they can have well-being. We're going to use this month's Wellbeing Wednesday to have a discussion about alcohol and alcohol disorders, and we couldn't be more pleased than to be joined by Dr. George Koob, the director of the National Institute on Alcohol Abuse and Alcoholism. Doctor, would you mind giving our audience a little sense of yourself and your institute?
Yes, so I'm director of the National Institute on Alcohol Abuse and Alcoholism, and our mission basically is to provide evidence-based information about the diagnosis, prevention, treatment of alcohol use disorder, and to study it across the lifespan. And so that's our mission. As a person, I'm a neuroscientist by training. Well, actually, originally a physiologist. So my PhD is in physiology. I have had an active research laboratory for almost 50 years, or participated in active research for 50 years, had a laboratory for probably about 40 years, and currently have a laboratory at the National Institute on Drug Abuse, ironically, but the director of the National Institute on Drug Abuse has a laboratory at the National Institute on Alcohol Abuse and Alcoholism. So we collaborate a lot together in our laboratory work, and of course, as directors of both institutes. I guess if you want to summarize my research, it's been to understand how the brain processes emotions in the context of addiction. I like to say that I spent the first half of my career trying to understand how we feel good, and I've spent the last half of my career trying to understand how we feel bad, and we'll probably touch on that a little bit later. So that's my basic background. I'm a Francophile. I enjoy everything French. I'm a gardener. I enjoy that. I like to travel and see new places and see new people.
Wow, that's so great. So thank you so much for doing that. It's wonderful to have you here. And I would imagine there might be some people in our country who are surprised that there's an institute at the national level focused on alcohol abuse and alcoholism, given how common alcohol is in our culture. And maybe could you reflect a little bit about, kind of the role, perceptions of alcohol and consumption in our society, and what do you see as some of the trends and things that your institute are trying to address?
Yeah, I mean, that's a really good question. And my answer is that alcohol is unique because it's not only a drug, but it's used by about 70% of the population. It's in many beverages, and it's basically the social lubricant. I mean, alcohol is in every opening reception, meeting, business meeting, virtually throughout the United States and the world. It's even served at every medical society I'm aware of during their opening reception. Maybe the American Society of Addiction Medicine is an exception to that rule. So alcohol is pervasive, and I think people don't realize that it is also a drug and can be a toxin when used and excessively and misused. And so we have 14.5 million individuals in the United States suffering from an alcohol use disorder. We lose 140,000 people a year to alcohol deaths. Alcohol is now responsible for half of liver disease in the United States. And so, there's an endemic alcohol problem in the United States. And there are many, many unique features associated with alcohol. Some of them are biological, but some of them are, major issues that, like fetal alcohol spectrum disorder, that really, I think the Institute is unique in being able to address these challenges, and they remain challenges. We're not going to have prohibition again. We did that; it didn't work. So, I think I see our charge as working with the American public to use alcohol when it's used appropriately, but also make everyone aware of the challenges we face when it's misused.
Yes. That statistic that you shared of the number of people who die every year from alcohol misuse, it's quite staggering. And, I have said several, frequently when I'm in public, talk about certainly the number of people dying from accidental overdose associated with opioids and other drugs is horrifying. And yet it is also true that more people die from alcohol. And unfortunately, it's probably a little more insidious and happens over a longer period of time. So the toll on individuals and families and communities is staggering. I've lived through the last 3 years, which have been rather bizarre. I would much rather read about pandemics in history books than live through them. And certainly it seems that the research seems to be indicating that alcohol consumption has been up over the last few years. What have you noticed in terms of patterns of use, and has that been common across all age groups and other factors in our country?
I think your intuition is correct. Alcohol use has been increasing over the last 20 years. The gap between men and women drinking, where men used to drink much, much more than women, has been closing for the last 50 years. But something really unique did happen during the pandemic, and we had a 25% increase in alcohol mentions on death certificates. And we've had a significant increase in consumption by about 25% of the population. And what we're picking up is that alcohol is being used to cope with stress. And historically, we've always known that, but the pandemic has really illuminated that part of the alcohol misuse problem. And so, there are a lot of stressors that were associated with the pandemic. Isolation, we're not interacting with our fellow human beings. And that's one of our, primary reinforcers in our world is another primate, ourselves. And that was denied us during the pandemic, necessarily so certainly in the initial stages. And then the job insecurity and for many, many millions of people, and then the issues of fear of getting the virus and worry about loved ones getting the virus and so on and so forth. And you know all that. But those are stressors, and those stressors tend to, induce people to drink because they get a short-term relief from the stress and even the memory of the stress that they're enduring. But unfortunately, it backfires, and you'll probably hear me say this again. And so you end up drinking to fix the problem that drinking causes, because drinking exacerbates all the stressors when the alcohol wears off. And so we know that alcohol drives the brain's stress systems, and as a result, you're actually making yourself worse in the long term, even though you feel better in the short term.
Wow. So I think that leads us into our next question, right? We talked earlier about the impact that alcohol has on increased morbidity and mortality, but could you talk a little bit about how alcohol consumption affects physical and mental health?
Well, basically, there are 200 disorders, maybe is a better word, that alcohol can exacerbate or make worse. Some of the more primary ones are kind of obvious, like liver disease, given that alcohol is responsible, as I said earlier, for half of liver disease in this country, but pancreatitis, gastrointestinal problems, and cancer. I mean, the National Cancer Institute now estimates that alcohol contributes to something like 4 to 6% of cancers. And truthfully, there's no completely safe amount of alcohol, because even at the recommended dietary guidelines for alcohol consumption for women, which is 1 drink a day, there's still epidemiologically an increased likelihood of breast cancer. And so, I think just about every organ of the body is compromised with alcohol. When it comes to mental illness, we know that there's a high comorbidity with alcohol use disorder and depression, anxiety disorders, PTSD in particular. Another situation where we have what I call self-medication. People are drinking alcohol. Maybe it makes them feel better in the short term, but what they really don't realize, individuals with PTSD often get into trouble with alcohol by drinking to fall asleep. And yes, alcohol will briefly shorten sleep latency. You'll fall asleep a little quicker, but unfortunately you wake up in the middle of the night needing to go to the bathroom, number one, and your brain is hot wired at that point, because all that suppression of activity now comes back with a vengeance, and your brain is hyperactive. And so you end up and then you can't sleep at all. And so basically alcohol, again, in the long term is making the situation worse, even though in the short term you think it's helping you. Same with depression and anxiety, because one of the symptoms of even a hangover can produce anxiety. You can think of a hangover in my book as a mini withdrawal syndrome, but alcohol withdrawal is characterized by profound anxiety and dysphoria and lack of pleasure in normal activities. And some of those symptoms will persist for long periods of time during alcohol withdrawal. And they, of course, then you ultimately don't know, is this the depression coming back, or are you worsening the depression? And so there's a big interaction with mental illness. It's something that's a real challenge for us at the Institute, and we work with the National Institute of Mental Health on these exact issues.
Yeah. Well, I'm trying to reconcile 2 things that you've mentioned. One is the pervasiveness of alcohol use in this country, with the comment that you just made that even following the recommended amounts of alcohol have health effects. And just wondering, how to reconcile those two things.
Well, I think to be honest with you, there are just some people who probably shouldn't drink at all. All right. And so if you're a woman with a history of breast cancer in your family, you should talk to your physician about it. I mean, having a small amount of your favorite beverage may be fine, but you should talk to your physician about that. People who are pregnant should not drink at all. People who are thinking of getting pregnant should not drink at all. If you look at your family history, and there's a huge apparently genetic loading of alcohol use disorder in your family. I have lots of friends who have had that history in their families, and they choose to join Al-Anon and not drink at all and protect themselves. If you're an Asian American, and there are about 30% of Asian Americans have an altered allele for acetaldehyde dehydrogenase. That's a lot of big words to say that when they metabolize alcohol, they get a flush reaction because their body spikes, their liver spikes the production of acetaldehyde because it's not being broken down. And acetaldehyde is a toxin, it's a carcinogen. And so individuals who try to drink past that flush reaction have a tenfold higher likelihood of esophageal cancer. So these are kind of the facts that, we're trying to get out to the public, and we'll talk about that later probably. But, there's a lot of information that our institute has. It's all on our website. We can start with that. If you all just type in NIAAA, you're going to find a wealth of information about alcohol that maybe you didn't know. One that just came up is, there was this, well, maybe I shouldn't get into this, but, there was this media stuff about people cooking with NyQuil. And NyQuil contains 10% alcohol.
I just saw something about why you shouldn't cook your chicken in NyQuil. I had no idea what it was about.
Yeah, well, it's basically could be quite dangerous given that NyQuil contains a number of 3 drugs, but also, 10% alcohol. So,
wow. Well, doctor, you mentioned, that people who might have different risk factors or should talk to their physician about drinking. And I would imagine that's, true that for most of us, we have family physicians, and those are the people that we would talk to. But it seems like according to research, only about 20% of the people who have an alcohol use disorder seek treatment. And just wondering about that statistic, what are the hurdles? What are preventing people from seeking treatment? Is part of it the lack of knowledge of physicians? What are some of the other factors?
So it's actually worse than that from our statistics. It's probably less than 10% of individuals get any treatment whatsoever. And there are actually 3 approved medications approved by the FDA, medications for the treatment of alcohol use disorder, and less than 2% of individuals actually get a medication to help them along the way. What are the reasons? Well, one of the biggest problems that we see is what we call the treatment gap. And that's more or less what you described. And that treatment gap, and what we've been talking about is this treatment gap. And part of the problem is that we really need screening and brief intervention and even referral to treatment for alcohol use disorder. So people are asked by their physicians how much they drink. In the studies we've seen, it can be 70 or 80% of people are actually asked that question. But that's the good news. The bad news is when it comes to referral to treatment, it plummets to below 15% of any, intervention. It plummets to below 15%. And so no advice is given. And then there's even poorer response for referral to treatment. And so we're trying to up our game in this regard. Screening and brief intervention and referral to treatment is approved by the U.S. and recommended by the U.S. Preventive Task Service for adults. And I would like to see every clinical healthcare provider ask individuals about their alcohol consumption and also give some advice. And so one of the things we've just done, and I was going to save this for later, but I'll bring it out now, is we've just launched in May what we call the Healthcare Professional Core Resource, which is 14 units of information. It ranges from what is an alcohol use disorder, a brief one about how the brain changes with an alcohol use disorder, what is screening and referral to treatment, how to do it. And then you asked about medical complications. There's a whole section on medical complications that's very detailed, but at a level that I think people can understand with references and sources to go to. Same for drug interactions, another big issue with alcohol, particularly with the elderly, and so on and so forth. And this is for everybody who's in healthcare. Could be a pharmacist, nurse practitioner, physician's assistant, nurse, clinical psychologist, primary care doc is where we aimed it, but also even a board certified addiction medicine specialist. And the public can use it as well. There's lots of good information in what we call fondly the HPCR. Everybody knows what a PCR is now, but this is the Healthcare Professional Core Resource, PCR. And this document, you can get CME credit for it if you are a healthcare professional. It has bullets at the beginning that kind of give you the bottom line. And it has the text, which is not too long, really. And then there are references and there are sources you can go to for videos and information. So we really recommend that. And then there's also the NIAAA Treatment Navigator, and that was put out now by us a number of years ago, and that's to help people actually understand what an alcohol use disorder is and understand the spectrum of treatment that's available. I'm sure you're aware that behavioral treatments are very effective for alcohol use disorder. Individual therapy, group therapy, Alcoholics Anonymous, motivational interviewing, cognitive behavioral therapy. These all are work. They're all effective. Not one size doesn't fit all. Some are outpatient. You can go to an outpatient facility and have your dinner there and work in the evenings. Go home afterward. You don't have to disrupt your professional life, so on and so forth. And we hope that this, and in addition, you can actually type in your zip code in the NIAAA Treatment Navigator and find a treatment facility near you. We use the SAMHSA, Substance Abuse Mental Health Services Administration locator, and also the Psychology Today locator. So, I think we are trying very, very hard in 2021 to 2022, both years, to get information out to that is evidence-based for the public about alcohol, and we hope to turn the tide on the closing the treatment gap. That's one of our number one priorities.
Well, Wash, I look forward to taking a look at your HC-PCR, and I feel bad that I have not done it yet, but I dedicate myself to. But I was going to actually tell you, we developed several years ago, the National Council did a change package for primary care practices for implementing SBIRT. Because I think one of the things we discovered is that folks really were, even if they understood the notion of a brief intervention, they needed some help thinking about how to structure it. And so what we tested this with a bunch of primary care practices around the country and have refined it. And I'll make sure to share it with you. But yeah, I just want people to know there are resources so that you don't have to start from scratch if you're interested in incorporating this kind of approach into your program. And I would even say for mental health programs, you should be doing this with your clients because they are a higher propensity to develop a substance use disorder as well. And it would be right, it's much better to catch it early and to intervene than it is to wait till people advance. The other thing that you mentioned, you talked about the variety of interventions that are available to treat alcohol use disorder. You mentioned a wide variety of them. One that caught my attention was your mention of medication. And as as an adjunct or standalone. And I would just tell you a story. During the pandemic, I was at my primary care physician's office and started talking with the nurse practitioner, and when she found out what I did for a living, we started talking, and she was commenting on the fact that they've been seeing an awful lot of people coming into the practice with elevated drinking. And I asked her if she was using medications, and I may have mentioned one by brand name. And she looked at me blankly and she said, "I've never heard of that." And I was just surprised. And, so maybe could you just talk a little bit about, kind of what you've seen in the evolution of medications for the treatment of alcohol use disorder, and, what would you, what's kind of the situation now, and what would you hope to see?
Absolutely. And I have challenged the medical community, particularly those around medical school training, to whether they could name the 3 medications that are approved by the FDA for alcohol use disorder. And I suspect that most of the people in the room could not have named them. And, you want to challenge your primary care doc, ask them, or a clinical psychologist who works on addiction, ask them. There are 3 medications. One's disulfiram, which is Antabuse, which has been around for a very, very long time. And that's a tricky one because it makes you sick if you drink. And so it's something, people have to monitor the person taking it. And it actually works in a few isolated studies where they monitored the patients and made sure that they were taking it. But we have 2 other medications that have reasonable effect sizes. And number needed to treat is 12 for both naltrexone and acamprosate. There are meta-analyses documenting that. The naltrexone blunts the pleasurable effects of alcohol. So if you're interested in cutting back and you start taking naltrexone, you'll find that it really reduces the pleasurable effects of alcohol if you do drink. Acamprosate, on the other hand, is a medication that tends to reduce that irritability and just not feeling well within my own skin, to quote someone I heard many years ago. Feeling of abstinence and protracted abstinence helps reduce that form of craving, and also has a similar effect size as naltrexone. And people say, well, those are not a spectacular effect sizes. Well, they're actually the same effect sizes you see with serotonin selective reuptake inhibitors that are used to treat major depressive episodes. You would never deny a person with a major depressive episode options for a medication, and they've saved millions of lives. I would suspect that the same would be true of alcohol if these medications were used. And one of the biggest problems we're having is people just don't know about them. So you've hit the nail on the head. Coming along, there are other medications that the VA formulary uses as adjuncts, other medications that can help people with sleep during protracted withdrawal from alcohol, and sleep can be a driver of relapse. The American Psychiatric Association has those same drugs listed. They're, at this point, they're not approved officially for alcohol use disorder, but being used as adjuncts. And then, there are quite a few medications that we're developing, or the individuals we fund are developing, that, are moving through the system. But, I hate to be discouraging, but I think the average is 15 to 20 years to get a medication from giving it to a rat to getting into people. And I think what the public needs to realize is that you have to get an investigational new drug application approved by the FDA. You can't just take what we do with our rodents and start injecting people with it. So, I think that those are some of the issues.
Yeah.
We're working on it, but it would be nice if the pharmaceutical industry was willing to buy in more to mental illness in general, and that better than I. And so, hopefully the tide's starting to turn again, and they're realizing that the scope of the problem, the pandemic has exacerbated the scope of the problem, and hopefully industry will step up to the plate in that regard.
Yeah, that would be nice. Just sitting here thinking about how complicated all this could be, but on the there's been so much attention at the federal level recently about the concept of harm reduction for opioid use disorders, and it seems perhaps this would be a little bit easier related to alcohol use disorder. Because in harm reduction, would we just be talking about modifying the amount of alcohol that one is consuming over time? Is that an approach that you support, or what does the evidence suggest there?
Absolutely. We are working with the FDA on this issue. We have, harm reduction from our perspective refers to strategies designed to meet people, quote unquote, where they are. All right, and in an effort to reduce the harms associated with alcohol, without necessarily asking them to go into full-blown abstinence and stop drinking. We just we have it in press. It was just published in the American Journal of Psychiatry, an operational definition for recovery. I think you may have seen it, where we make the argument that recovery is both, a process and an outcome, but we also make the point that we accept recovery as not meeting the DSM-5 criterion for an alcohol use disorder, but also not engaging in heavy drinking days. But we left out abstinence. All right, and so you can have a slip under our definition and still be on the road to recovery. And we're hoping that this operational definition will be adopted by researchers. One may not want to adopt it necessarily for a given client in your practice. That's up to you and the client. They may be better off after 5 DUIs, to be completely abstinent, but that's between you and the client. But if we utilize this operational definition, we can research and find out what promotes recovery. I've worked years ago before I joined NIAAA at a rehabilitation facility in San Diego. And they did everything there. They had all the behavioral treatments. They recommended Alcoholics Anonymous. They had medications available. They did biofeedback. They did cognitive behavioral therapy. They did yoga. But 2 years out, they don't know what really worked. Was it the yoga? Could have been the yoga. Might have even been the yoga. So, I think this is something we're trying to stimulate research in this area. I'm sure it's very dear to your hearts. And so we are approaching a harm reduction, endeavor at NIAAA. And we're also working with the FDA to possibly utilize the WHO levels of harm associated with alcohol, and seeing if a certain number of reductions might also be a criterion we can use for medications development. So we've already originally had abstinence. We now have percent heavy drinking days as an outcome, and we're looking for WHO levels as another possible outcome. So I think these are all steps in the right direction. Obviously, the first thing might be that you consider abstinence, but we know that there are many people that don't want to go that route. Maybe a teenager or a young person who got in trouble with alcohol, they may very well be able to return to some form of controlled drinking later in life, and when things settle down and they're no longer partying with their friends and on a given night, really getting into problems with alcohol. And so we're trying to be much more realistic, and I think that the whole field is. And in fact, someone was asking me about this a while ago, and I basically told them that we got there first when it came to harm reduction. I mean, Alan Marlatt argued this, 30, 40 years ago. But I think now we're taking evidence-based steps to support the concept of harm reduction in the alcohol community.
Well, that's really great to hear. And, I'm just reminded of, this notion of multiple pathways to recovery, that people are going to need different things at different times, and being able to calibrate expectations accordingly. And what are we doing that's promoting health, and well-being without being fixated on a particular outcome? So thank you so much for that thoughtful reply, Doctor. Earlier this year, I had an op-ed published in the USA Today. I like to tell my children that. And following it was really kind of looking at the impact that alcohol has on our country and on individuals. But I received a very nice email from Dr. Wesley Clark. Isn't he out in San Diego now, formerly from SAMHSA. And he, kind of pointed out the variation in funding within the National Institutes of Health for the various centers. What do you kind of think about what does our country need? What kind of investment does our country need in order to really address the seriousness of alcohol in our country?
Yeah, so Wes Clark is on our NIAAA council right now, and he's one of my favorite all-time people. We think a lot alike. He's a great man, and he's done some major contributions to the field. The research holds promise in helping the country with the challenges that we've discussed here today, and more research is needed. Okay, that's a given. The other point I would like to make is the effects of alcohol are overwhelming, and given our resources, we're going to need help from other federal agencies, federal partners, healthcare providers, and others to close the treatment gap. And so, a basic first step, and that's why I mentioned it earlier, is getting the healthcare professional core resource, the HPCR, out to providers. And so you all can be ambassadors to that. We encourage you to do so. And I forgot to mention earlier, but I think it's really important to mention that, these are living documents. So if what you told me about how you've got a really good way of interfacing with healthcare providers for screening alcohol, please send it on to Bridget Williams-Simmons, our head of science policy at NIAAA. And, if it's not already in the healthcare provider, we'll get it in there. I and anyone else who has ideas. I mean, everything we do now is a living document. Our website's a living document. NIAAA Treatment Navigator is a living document, and so forth. And then I think your audience knows about Rethinking Drinking, but one of our most popular websites is Rethinking Drinking, which really basically tells you some of the factoids that we've been talking about, but even defines what is a standard drink. So you know what the heck we've been talking about. So, I just thought I'd mention that. But I mean, we have a lot of great programs, and we hope that we can start working with other people to scale them up and get this key information about what's available out to the public. And of course, we're devoting a lot of resources to developing new medications, to developing new behavioral treatments, to developing better prevention. These are big issues to work on interventions and prevention of fetal alcohol spectrum disorder. So, these are really high priority areas. And I need to mention that one of the biggest priorities we have currently is diversity, equity, and inclusion in who we study, who we help, who works on alcohol, researchers, and et cetera. And, this is, there are pockets of individuals in our country underserved for years. And we really need to put a lot of energy into making sure that all these things are equitable now. And, that is a big effort at NIAAA.
Well, I commend you for that effort. I think it's really important. And, there are so many factors that contribute to that disparity. And I know the National Council trying to do what we can to help treatment organizations meet the needs of this population. Well, Doctor, I had the pleasure of asking you a whole bunch of questions. I just wanted to see, before we wrap up, is there anything else that I didn't ask you, or anything you think we missed?
Well, I said this on a podcast recently for another group, and I'll repeat it today. Because I'm a physiologist and because I have studied the brain, one of the statements I used to tell my undergraduates, and I taught at the University of California for many, many years, a lot of big courses on addiction, is that with drugs and with alcohol in particular, there's no free ride in the brain. Right. So, we use them as social lubricants, but if you overdo it, you're going to pay for it the next day. And we call that a hangover. And the same goes with utilizing it to self-medicate problems and coping with stress. If you overutilize it or inappropriately utilize alcohol, your brain is going to come back with a vengeance, and you need to remember that. So I think that would be one thing. And then for your group, I would say, and this is a bit far out, there was a lot of discussion about the etiology of the opioid crisis and the concept that pain was the fifth vital sign. I don't think pain should be the fifth vital sign. I think alcohol should be the fifth vital not sign. In other words, we should be asking, just like you take blood pressure in a when you go in for your physical or go to see the doctor for whatever, I really like to see us adopt that alcohol would be asked. And, the Audit C, which your group is probably familiar with, is just 3 questions, takes 2 minutes. And, that should be in every physician's office, every clinical psychologist's office. Alcohol misuse is a window to other medical complications. Could save you a lot of time rooting around trying to figure out why somebody has a gastrointestinal problem when it's actually because they're drinking too much. Yeah. I hate to be so boring, but that's the case.
Well, but I think that's the reality, right? We know that mental illness and substance use disorders have a tremendous impact on our physical health, and it drives up costs in our healthcare systems, and obviously complications for individuals and communities. So we take that boring, very important to think about. So, Dr. Koob, thank you so much on behalf of the 3,200 members of the National Council, on behalf of all American citizens. Thank you for the incredible work that you're leading at the National Institute on Alcohol Abuse and Alcoholism. I hope our whole audience will join me in thanking Dr. George Koob for being with us today. And we hope that all of you will join us for our next edition of Wellbeing Wednesday. Thank you very much.
Well, thank you, Chuck. It was a real pleasure and absolutely great questions. So thank you.
Thank you.